Tell Dr. Dhamija that to please accept.
Yes, sir.
Yes, come.
Sir, he
Yes.
is in panelist now.
Yeah, yes.
Thank you, sir.
Okay. There is. Okay, so let's.
Good of you from across the world. Are you in US, Dr. Nirmal Surya, or you're back in Mumbai?
Welcome, sir. I'm in Mumbai waiting for you.
Okay, good.
Hello, everybody. You are all
Good afternoon, sir.
welcome to the webinar on occasion of World Parkinson Day, which was celebrated from yesterday. We have this public awareness program of multidisciplinary team is brought to you by multiple organizations coming together with IFNR and WFNR being leading for jointly by WFNR, SIG of Movement Disorder, Developing World Forum, and Neuro Rehab subsection of Indian Academy of Neurology. As you can see that we have joined the multiple organization and we have the multiple disciplinary team. So the world now has to move together, we achieve more. So more organization coming together, more number of people coming together to help the people who are suffering from any neuro disability, and in Parkinson's particular, where we have an expert along with me is co-chair Abhishek Srivastav. Everybody knows him. He's director, chairman of Neuro Rehab at Kokilaben Ambani. Today moderating the session is Guhan Ramamurthy, who is the youngest neuro rehab specialist in India, and he's the secretary or convener of neuro rehab subsection of IAN. And the top of the leader is Dr. Dhamija, who is the chair of the movement disorder subsection of WFNR. Not only that, he is the director of IBAS, the Central Institute in New Delhi. And he is also the chairman of the Brain Task Force of Niti Aayog, Government of India. With that, we also have Dr. Urvashi Shah. She is one of the most senior and the first neuropsychologist in the country with experience of more than 40 years. So we are really lucky to have such great experts here to tell you about the Parkinson disease. And not to forget, the multiple disciplinary team cannot run with neurologists or PMR specialists or even the neuropsychologists. We have physiotherapists, we have speech therapists. So we have a couple of very, very senior people. Radha Bhattad is the physiotherapist. Then we have Mr. Jagirdar, who is the occupational therapist. Prasanna Hegde is well-known speech and swallowing pathologist. And Lukesh Guer is the orthotic. So it is truly a multidisciplinary team. We lack one social worker. I think I will act as a social worker today. So with that, I would hand over to the Guhan because he is the one who's going to moderate. But I just want to say that Parkinson disease is no more a rare disease in India. Nearly 9 lakh people are suffering from Parkinson disease in India, which forms about 10% population of the world, where we expect about 90 lakh people suffering from Parkinson disease. The number is going to be double in next 10 years time. So as the age increases, the longevity increases, the more number of patients are bound to be there. And not only the motor, ADL, speech and swallowing, cognitive, assistive technology, they might require many more new things along with the care when newer and newer drugs are developing, newer and newer remedies are developing. So today we'll hear from all these experts. Before I hand over to Guhan, I want Abhishek to say a few words and then hand it over to Gohan. Over to you, Abhishek.
Good afternoon, friends. I think it's a great panel to have with joint efforts of multiple teams coming together. And as Sir has told that PD is quite common. Also, what's becoming more common is extrapyramidal symptoms in patients who have stroke or traumatic brain injury, which itself is a big burden. So we can actually numbers are double up than PD plus stroke and TBI causing any symptoms. So there's great need for people to get multidisciplinary team involvement because the impairments are multiple and pharmacotherapy, as we know, is not enough or sufficient to treat those symptoms. Let's discuss how beyond pharmacology we can help our patients with Parkinson disease and Parkinson's symptoms. Over to Gohan. Thank you.
Thank you, sir. First of all, I would like to thank my mentor, Dr. Nirmal Surya, sir, and Dr. Abhishek Srivastava, sir, the chair of the Neuro Rehab subsection of the IAN, for giving me this wonderful opportunity to moderate this esteemed panel discussion. And I really feel privileged to be a part of this panel discussion. And it gives me immense pleasure to welcome everyone here to the public awareness program on Parkinson's disease beyond the pharmacology. And this initiative, as Surya sir has already mentioned, is a collaborative effort. And it's rightly so that I start with the introduction of Dr. Nirmal Surya sir, though he's a person who does not require introduction, but just for being on the records. He is the Secretary General of the World Federation of Neurorehabilitation, the President of Indian Federation of Neurorehabilitation, the past President of Indian Academy of Neurology and past President of Indian Stroke Association, and he is currently the President of the Asia Oceanian Society of Neurorehabilitation. And he has received a prestigious Kenneth M. Wiste Jr. Award and Patient Advocate of the Year Award and Patient Volunteer by the award by the American Academy of Neurology. We welcome you, sir, and thank you very much for chairing the session, sir. And can I have the next slide? Just an overview of our the other panelists, though sir has already introduced. Dr. Abhishek Srivastava, sir, is the Director of Center for Rehabilitation at Kokilaben Dhirubhai Ambani Hospital. He is the chair of the multiple sclerosis SIG at the WFNR, and he is the chair of the Neuro Rehab subsection of the Indian Academy of Neurology, and he is director at the Indian Federation of Neuro Rehabilitation. Can I have the next slide, please? Next slide, please. Next slide. And amongst our elite panel, the top neurologist in the country, that's Dr. Rajendra Dameja, sir, who heads the IHBAS, being the director of the IHBAS. He's a professor of neurology and director at IHBAS, and he has more than 120 publications. We welcome you, sir, for joining us on this elite panel discussion. Thank you, sir. Next slide, please. We have the most experienced cognitive psychologist in the country, Dr. Urvashi Shah, ma'am, who is a consultant neuropsychologist at the Department of Neurology, KEM, Mumbai. And she has over 30 research papers, 9 chapters, and over 100 national and international presentations with several achievements and awards to ma'am's name. We welcome you, ma'am. Thank you so much for being with us today, ma'am. Next, we have a wonderful physiotherapist who is specialized in rehabilitation of Parkinson's disease. She is Dr. Radha Bhattad, the Vice Principal, Professor and HOD, Neurophysiotherapy, Sanchetti Institute for Orthopedic and Rehabilitation, College of Physiotherapy, Pune. We welcome you, ma'am. Thank you so much for joining us today, ma'am. We have an experienced occupational therapist, Dr. Sri Harsh Jahagirdar, who is an assistant professor of occupational therapy at TN Medical College, the Nair Hospital, Mumbai. We welcome you, sir, for joining us as an occupational therapist. We have a wonderful swallowing therapist in our panel, Dr. Prasanna Hegde, who has completed his master's in speech and language pathology. He is the program director at HCG Hospital, Bengaluru, and president of Isha Bengaluru chapter. We welcome you, sir. We have a speech therapist today, Dr. Jyoti Mohite. Ma'am is Associate Professor, Audiology of Speech Therapy School at the Nair Hospital, Mumbai. We welcome you, ma'am. Thank you for being with us today, ma'am. We have Mr. Lukesh Kumar Buyar, the expert in orthotics and prosthetics, from the All India Institute of Physical Medicine Rehabilitation. He has completed in Masters and Bachelors in Prosthetics and Orthotics. We welcome you, sir. Thank you very much for being with us today, sir. With a short introduction of our esteemed and elite StarCast panel today, we now are going to begin our interactive panel discussion. And we have made it careful that it's designed around real-world question, posed in simple yet relatable terms to help patients and caregivers get practical insights from our experts. So let's begin and get straight to the heart of the matter. My first question to Dr. R.K. Dameja, sir. When people think of Parkinson's, they usually think of tremors, the motor symptoms predominantly, the slowness. But there are things beyond these motor symptoms that lies hidden within the facade of the Parkinson's patients. The symptoms that are less obvious but yet equally impactful. Sir, can you please highlight on the motor and the non-motor symptoms of Parkinson's disease that often go unnoticed and how important it is in the early recognition? Over to you, sir.
So, good afternoon, everyone, and thank you, Dr. Guhan, for organizing this patient awareness session on World Parkinson Day, which was yesterday. I would start by complimenting and congratulating Dr. Nirmal Surya for his another achievement. Last week, he got an award from the American Academy of Neurology. And I take this opportunity on behalf of all of us panelists as well as the audience to congratulate him and thanks him for bringing glory to the nation and taking the Indian flag high at the various international fora. So congrats, Dr. Nirmal Surya. Once again, you are the hero of and the father of neurorehabilitation in India. So Parkinson disease, as you know, I'll try to speak in Hindi and English both, because I think the audience is caregivers as well as the patients and the healthcare professionals. So Parkinson disease actually is named after Dr. James Parkinson, who was 11th April 1755 in London. He described the first cases of paralysis agitans, what we call now the Parkinson's disease or idiopathic Parkinson's disease, which is named after him. So this is a progressive disease, lambi bimari hai. This is due to deficiency of a neurochemical called dopamine, which is produced by our striatonidal cell in the brainstem. तो जैसे जैसे उम्र बढ़ती है, कुछ लोगों में the cells they die and there is a deficiency of dopamine, जो कि हम बाहर से देते हैं, and we replace the deficiency of dopamine by giving the levodopa drug. जो मेन इसके जो लक्षण हैं, जो मेन symptoms are, we call it TRAP. The T for tremor, R for rigidity or tightness, A for akinesia or bradykinesia or slowness, and P for postural imbalance or postural difficulty. So for more motor symptoms, four basically. So tremors, that means shaking, and then the rigidity, the tightness, and then of course slowness, and then the balance problems. So these are the motor problems. But as you rightly said, there is a hidden umbrella of symptoms which are not visible, and they start right from the 20th before the disease begins. 20 साल पहले से, तो something like anosmia, the loss of power to smell, or say constipation, or what we call the REM sleep behavior disorder. So they all start years before actually diagnosis is made. They are called prodromal symptoms. So obviously they sometimes go unnoticed, but they are very relevant, very important. Once the diagnosis is made by the clinician or a neurologist or a physician with the slowness, difficulty in speech, difficulty in writing, difficulty in getting up from the bed or from the car, getting down from the car, or doing the daily activities like shaving, brushing, or buttoning. So these people take more time. So that is something which alarms us or which gives us that patient may be having Parkinson's disease. The most important thing is it starts on the one side. So it's asymmetrical, unilateral. And then extend to the, for example, if it starts from one hand, then it will go to the foot, right leg or the left leg, and then it will have the bilateral side, the both sides. So it's very important to know that it's a one-sided affair. The one side gets affected first, and then it goes to the second side. Coming to the symptoms which are known motor symptoms. So they are very important in the patient's morbidity and the quality of life, and that is something like speech and swallowing problem, because everything is slow in patients with Parkinson's disease. So there's a collection of saliva or pulling of saliva in the mouth because patient is not able to swallow, or there's a slowness in swallowing. So that becomes a difficulty. There's a drooling, and patient is not able to swallow. Sometimes you get your food and fluids in the trachea or windpipe. That can create a problem in the aspiration pneumonias and things like that. So that is very important. The other thing is sleep problems. So patient will get a problem in the sleep. Either they don't get the sleep, enough sleep, refreshing sleep, quality of sleep, as well as the quantity of sleep becomes less. So people will have sleep problems. And then again, sleep and behavior disorder, where people will act as if vivid dreams and they get up suddenly, or some people walk in the sleep and they will have the movements of the legs or the toes. And that is a big problem for a partner and for a person suffering from the Parkinson's disease. There are so many other non-motor symptoms. Pain is very important. Many of these patients will go to orthopedic surgeons first or rheumatology because the patient will have backache or the joint pains because of the stiffness and because of the rigidity, tightness. So many of these patients will first consult a orthopedic surgeon, and the pain is again a very, very important symptom. In addition, there are urinary symptoms, there are sexual problems, and there are so on and so forth. Lots of non-motor symptoms are there, which we can discuss in subsequent sections. So over to you, Dr. Guhan.
Thank you very much for highlighting on the motor and the non-motor symptoms in Parkinson's disease, sir, and summing it up beautifully. Now coming to Dr. Urvashi Shah, ma'am, the cognitive psychologist in our team and the panel. Ma'am, Parkinson's can deeply affect the mind. Memory, attention, and emotional balance often take a hit, but many, they don't realize it's a part of the disease. Can you elaborate on these challenges and how they can be managed beyond medications, ma'am?
Thank you very much, Dr. Gohan, for that question. And first of all, thank you to Dr. Surya, Dr. Abhishek Srivastav, the Indian Academy, for involving me in this lovely panel. So if you know and you've read that James Parkinson actually, when he first described Parkinson's disease, he called it a shaking palsy. And I think that term shaking palsy set everyone thinking about Parkinson's for a very long time as a motor disease. So you were always focusing on tremors, कंपन के बारे में बात करते थे, बैलेंस के बारे में बात करते थे, और ये किसी को ख्याल ही नहीं आया काफी समय तक that there is something else that is also going on in the brain related to Parkinson's. And those are the changes which are happening in cognition. Now, cognition is a very complex word, वो बड़ा सा सब शब्द है, लेकिन very simply it's the functions of your brain. उसमें आप attention सोचो, ध्यान देने की शक्ति, memory you look at, your planning abilities, and I'll talk a little about that. तो ये are quite common with Parkinson's disease. And when we say common, तो हमसे पूछा जाता है कि what do you mean by common? How common is it? So first of all, I want to say very clearly, not all people with Parkinson's disease have cognitive problems. So be clear about that. So who are the kind of people who get it? Roughly, approximately, it has been said, and it's a large number, that's why we are talking about it, that almost 20% to about 50%. So you're saying 1/4 to almost half the people with Parkinson's disease will have something we call mild cognitive impairments. Now, when we say mild cognitive impairments, there is some difficulties, and they can start very early in the disease. But as the disease progresses and you get more advanced disease, you may even have a dementia. And in the dementia, far more symptoms occur, more cognition impairment occurs, and the person has far more difficulties. But very quickly now, what are the kind of questions I get from patients and family members? First, they ask me, what exactly gets affected when we talk about cognitive difficulties? So the main thing we find in the Parkinson's kind of cognitive impairment is slowing. So, we talk about motor slowing, which we talk about bradykinesia, the term they use in medical jargon. But here we talk about bradyphrenia. Bradyphrenia means your thinking, आपकी सोचने की गति बहुत slow हो जाती है. And why this is important for you to understand? कि कई बार the family members or others who are talking to you get very tired talking to you because you're not grasping fast enough, you're not answering fast enough. तो लगता है कि इसको शायद पता नहीं है. पर पता नहीं है. The brain is slow, it has the answers, but it's not able to give it out very quickly. Then you have problems with what we call executive function. मतलब plan कैसे करना, how do you organize the day, multitasking, two things that together you cannot do. The physiotherapist will tell you about how they train you for dual tasking, how to walk and do and think at the same time. So these are problems you find with executive function. Forgetfulness. What did you have for breakfast? Recent memory. You didn't tell me that. I don't think you have told me. The wife will say he's constantly accusing me of this. So forgetfulness that may occur. Sometimes there's visual-spatial problem, forgetting the way, not able to navigate your way through certain routes, and also related sometimes to hallucinations and the behavior problems. And sometimes communication, that you're not able to get the word very quickly. You're slow in your fluency. You're unable to give long sentences. And now this MCI, when it occurs, mild cognitive impairment, you're able to do all the activities. So whether you're cooking, planning, in going to the bank, remember in MCI, you can do it. When we say someone has dementia, they are unable to do even these activities and even the self-care activities, and it becomes far more severe. Now, there are some sensitive issues. What the family tells us is the person is not willing to accept. Very often, persons with Parkinson's disease will not have insight. They will say, nahi, hame nahi ho raha hai. It's not my fault. She did not tell me. It's not that I don't remember, but she has not told me. So this insight, acceptance will help you adjust. And if you learn how to adjust, we can teach you strategies. So what are the strategies very quickly? Non-pharmacological. Medicines to kuch hai. There is some evidence for medicine, but largely they are non-pharmacological. So what do we say? Cognitive training. Cognitive training में दो बातें. First thing is, concept जो हम use करते हैं, use it or lose it. So brain के अंदर जो भी बचा है, it's a degenerative process. You're going to be losing more and more function. But जो भी है, how do you maintain it? How do you keep it up? So a number of things that you have to keep doing to stimulate your mind. So from puzzles, from Sudoku, from playing board games, from engaging in hobbies, learning new things, languages, music, go and learn how to dance, go out there and do new things. All that will stimulate your brain. And the second thing is now the problems that have occurred, you have to do compensatory strategies. So if you're forgetful, how do you write notes? How do you have reminders? How do you have phone call messages that come to you? So all these strategies, we don't have the time, but there are wonderful evidence-based strategies that we can teach you and optimize your life in an everyday fashion. And last but not the least is also the family. The family has to create a supportive environment. They have to accept, they have to understand, they have to give the cues to the person regularly, not accuse them. मैंने अभी आपको बोला, आप भूल गए. So how the family treats the patient is also important. And very quickly, as the last sentence, we do elaborate evaluations. Then we plan how to treat you and how to manage you. We rule out other conditions, whether you have some vitamin B12 deficiency, some thyroid deficiency, what are correctable factors which we can treat so that your cognition can improve. So this is just in a very nutshell, but just want to tell all the people listening, learn how to identify कि हाँ problem हो रहा है, and identify it, accept it, come to us. We will teach you the right strategies and the methods to lead a very good, powerful life despite having the cognitive problems.
Thank you very much, ma'am, for beautifully crafting the answer as to how cognition can be involved and how to prevent it, and even if one occurs, how to overcome it. Next, before we proceed to the next question, I would also request the attendees, if anyone has any question for our elite panelists, then you can please post it in the chat section and we can take at the end of the first round of questions, if any. Next, my question to Dr. Radha Bhattad, ma'am. Ma'am, medications that we use in Parkinson's disease, they treat symptoms, but independence for these patients, they need much more than that. How does your work tie the entire care of puzzle together? They say exercise is medicine, especially for Parkinson's, but when should the workout really begin? How early should physiotherapy begin? And can you shed a light on what forms of exercise are most beneficial for the Parkinson's patients?
Sure, sir. Thank you. Nice question. At the onset, I would like to thanks all the organizing team as well as all the collaborative efforts made by various academies. It is a much needed one, and thanks for it. As you have said, when should a person start exercising? And as you have very correctly said, exercises are the medicine for these patients. So I would say as soon as the diagnosis is made, the exercises should be or the physiotherapy should be started. The reason behind it is because we know we have to maintain, as said by Damija sir and ma'am also, that there is some rigidity जिसको हम tightness बोलते हैं या कड़कपना बोलते हैं जो उनको आता है, या मूवमेंट्स धीरे धीरे होने लगती है जिसकी वजह से उनकी फ्लेक्सिबिलिटी लचक जो बॉडी में है वो कम होने लगती है. So just to maintain the mobility, just to maintain the flexibility and prevent our secondary complications. What I mean by secondary complications is अगर हम कम चलेंगे तो हमारी मसल्स और टाइट होंगी और डीकंडीशन होते जाएंगी, हमें और वीकनेस आने लगेगा जल्दी जल्दी. सो ये कुछ कॉम्प्लिकेशंस होते हैं जहां हमारा बॉडी डीकंडीशन होने लगता है और टाइटनेस ज्यादा बढ़ने लगता है और मूवमेंट्स और स्लो होने लगती है. सो बॉडी इज सिंपली लाइक मशीन, इफ वी आर नॉट यूजिंग इट उसको जंग लग जाता है. सेम इज विद बॉडी. सो जस्ट वी नो एज सेड बाय सर कि इट्स अ प्रोग्रेसिव, थोड़ा धीरे धीरे करके डिसीज बढ़ने वाली है. We know it is going to increase, but what we can do is we can reduce the speed with which it is increasing, or at least make the person's life better. The quality of life can be improved. So one is to maintain, second is to prevent the आने वाले complications को हम prevent कर सकते हैं. So that's the reason exercises should be started as early as diagnosis. And the thing that ma'am was saying about neuroplasticity, या जो rule होता है use it or lose it. So neuroplasticity जितना जितना हम उसको यूज करते रहेंगे उतने सेल्स और उनके कनेक्शन बने रहेंगे हमारे ब्रेन में. सो इट इज बेटर टू स्टार्ट एज अर्ली एज पॉसिबल. Coming to the next part of the question, which kind of exercises? So I would say right from aerobic exercise to stretchings to strengthening mobility exercises, coordination and balance exercises. These all exercises, बहुत सारे प्रकार के exercises होते हैं, but my suggestion would be we can make a combination of it. And we now know that multidisciplinary team approach is required. So sometimes it can happen, we know the patient is cognitively challenged or has some mild cognitive problem, or we know the speech is a problem. So we can incorporate exercises, including all these areas also into it, so that patient किसी दिन cognitive rehab पे focus कर रहा है, किसी दिन movement rehab पे focus कर रहा है, किसी दिन speech rehab पे focus कर रहा है, so that the patient is not overburdened. And some exercises, simple exercises can be given or taught to the caregivers, because we know it's a long run where the patient will be there with us. So it is better some part of the exercises can be taken care by the caregiver or the people at home, and part of it can be taken care by the team members. I hope if that is the answer to the question.
Thank you very much, ma'am, for highlighting the importance of starting the rehabilitation physiotherapy early in the course of Parkinson's. Many patients, they believe the first time I have a fall, then maybe I'll start my rehabilitation program, but that's not the case. The whole point is to prevent the fall from happening in the first place. And my next question to Dr. Sriharsh, sir. Daily life becomes a battlefield for Parkinson's patient, right? From brushing the teeth to buttoning the shirts. So how can therapy restore not just movement, but dignity for these patients? How can people with Parkinsonism maintain their daily activity levels?
Yeah. Thank you for that question. And I really thank all the organizers for having me here on the panel. As an occupational therapist, our primary focus is the person as in function. That is, occupation in occupational therapy means that all that person thinks is important for him to survive, him or her to survive, and gives the meaning for their life. So most important part in Parkinson's is being occupied with functional tasks, or being occupied with what they want to do, is simple activities of daily living. So, as an occupational therapist, going beyond, like we all are talking about, reducing the impact of the disease, or reducing the progression of the disease. But what we look at as an occupational therapist is reducing the impact of these symptoms. And most importantly, the dignity goes, we believe in this theory of disengagement. Like when the person with Parkinson's has been diagnosed, the entire world changes for him and the entire family. What happens is the another non-motor symptom that is most prevalent and very relevant to occupational therapy is a mask face. the person with Parkinson's loses ability to express, loses ability to understand happy situations, and is more attuned to, the research says the person with Parkinson's are more attuned to understanding the sadness or the bad news of it, but never understand the happy feeling. So this becomes the major hindrance for them to occupy themselves into any kind of meaningful activity after the diagnosis is done. So how we help as an occupational therapist is one, definitely the exercises that we do, which are functioning tasks, and we use these function as a starting point of assessment as well as a means to treat them. For example, brushing an activity. So what is hindering brushing? So the person, the environment in which the brushing is taking place, and what kind of brush. For example, a normal brush, if the person is not able to handle, can an electric brush be helpful? Example, if the tremors are interfering with the activity of brushing, so can a brush with or a spoon be made heavy, or the girth of the spoon can be made larger so that the person engages purposefully in that activity. What we believe is the more they involve into their daily activities, the better their health remains, because they do not know the medication, they do not know the progression of the disease. That's quite alien to them. What they know is whether they can do that particular job that they want to do every day, especially toileting. So a simple environmental changes, if we get into the toilet, like using a non-skid mat or using a strip of neon strip so that they know where there is a step, and also using a raised toilet seat would help them to involve. Also, as they take a longer time to execute the motor patterns required for these daily activities, the labor of doing these activities increases. So, as an occupational therapist, we see to it that how the activity is more simplified so that the energy expenditure is less. And this goes in accordance with the medical fraternity. Like the activities which are most important to the patient are taken in the on phase of the medication, so that the person's participation is also good, and also the person is bodily ready about it. So to understand the person more, we need to have an extensive evaluation of the person himself and the environment in which what are the environmental hindrances and how we can improve the task, so that all three matches together to keep the person more occupational or more active in the daily living. I hope that answers the question.
Thank you very much, sir, for highlighting the importance of using the weight-based daily items that can improve the tremor, especially for those tremors that decreases with increasing the weight. And that was a wonderful highlight of overview of the occupational therapy that a Parkinson's patient would need, sir. Before we proceed to the next question, there's a request from one of the attendees that if the conversation is in English, it will be easy for them to understand. Just with this request from the attendee, I proceed next to our speech therapist, who is part of the panel, Dr. Jyoti Mohite, ma'am. Ma'am, voice is one of the identity of the patient, and changing voice can be heartbreaking. Can you highlight why is speech therapy important for people with Parkinsonism?
Thank you. At the outset, I thank all the IFNR team for making me a part of this prestigious panel. Now, coming to your question, yes, voice is the identity of one's personality. As everybody till now, they have said that it is a disease which is progressive in nature. And there is going to be slowness in their thinking, their everything. So the communication is going to get definitely affected. Now, coming to specifically to the voice, when you produce voice, we need to have coordination of your respiration as well as your laryngeal muscles. Now, there is slowness in all of these things, so that coordination gets affected, and over a period of time, that the voice, the effort that the person is going to need to produce the voice is going to be more and more. So they're going to find it very difficult to produce the voice, to make this coordination. That is because the laryngeal muscles are also going to get affected in this disorder, and slowly that is going to deteriorate with time. So therefore, your voice gets definitely affected. And in speech therapy, yes, we'll work on this coordination of respiration and phonation, as well as in initial stages, as ma'am said, if it is a mild impairment, if a person comes in the initial stages, yes, your aim would be to make this conversation or communication better using speech to improve their intelligibility, because their tongue muscles are also going to get affected and the intelligibility of speech is going to get affected. But over a period of time, when the voice is, so the disease is progressing a lot, communicating is going to be very, very difficult. So we also have to prepare them for use of AACs. Additionally, what we say in this particular Parkinson's disease, you also find the person's facial expressions also become like mask-like thing a little later on. They do not show this facial expressions. So when you communicate, your words are communicating, yes, your 30% and probably the rest of 70% is by your facial expressions, your body movements and all those things, which is again going to add to their communication difficulty. So we need to tackle all this. And also, obviously, later on, Prasanna will talk about more of the swallowing difficulty also, which they face. Thank you.
Thank you for highlighting the speech part, ma'am, and especially the importance of speech therapy in patients with Parkinsonism. Now, coming to the swallowing therapist in our panel, Dr. Prasanna Hegde. Sir, swallowing difficulties are a silent threat for patients with Parkinsonism, and it's usually missed until it's too late. What are the warning signs we should never ignore in these patients, sir?
Dr. Govind, thank you very much for the question. I mean, it is very relevant because you already said it is a silent problem. And at the outset, thank you for giving me the opportunity to make some of the points which is already in the literature and also in the experience that probably is there. Early signs are usually missed by most of the clinicians, and some of the things are already put forth by the panelists, like Dr. Urvashi said about insights. So what we have seen in our clinical practice is that there is unreasonable, complaints about their spouse, saying that no, they keep complaining about the food and other stuff. There is mismatch between the spouses. That is the first beginning. Now, if you go back to all the history in these people, you find that the complaints had already started way back. And there is also another things about control. You might probably find some individuals not able to control the saliva. They're spitting while talking, or even during the meal time, they're able to eat well, but saliva they're not able to control. There is a very initial signs of dysphagia, especially about saliva itself. And they might take a longer meal time for specific food. Even probably they will do well with liquids, but the moment it is hard, probably they have more sluggish problems. They might probably take much more time than their age matched controls. And if we are able to look at least cough for liquids, or specifically water, when they are having water, and they might cough, they might say, they might have throat clearing. But beyond coughing for liquids, if we are able to identify anything other than like gurgly voice, we are already late. So cutoff would be at the point when a person with Parkinson's disease, so probably suspected with Parkinson's disease, is coughing for water. Now, beyond that, it is going to be our probably inability to understand.
Thank you, sir. So if there's fight between the spouse over the food, start exercising your swallowing muscles.
Yeah.
That's the way to go for Parkinson's patients. And coming to a very important part of Parkinsonism, orthotics. Mr. Lukesh Kumar Buyar, sir. Technology is transforming rehabilitation, one smart device at a time. And how can we customize these innovations for real-life Parkinson's needs? How can wearables and smart mobility aids be customized for PD at different stages? Over to you, sir.
Yeah, thank you, Dr. Guhan. Thanks for inviting me for this session. I'm very much thankful to IFNR for this invitation. Coming to the question, as we say, if we divide these stages of Parkinsonism in a primary stage and in later stage. In a primary stage, providing them with orthotic support or assistive devices like canes or other assistive devices, it can be helpful to the patients. Then AFO, ankle foot orthosis, orthotic intervention, help them to have a better control during their walking, and the risk of fall can be reduced by that. There are variable sensors also that can detect the falling tendency, or when the patient is going to be fall or something like that. Then vibrations and that can happen. So that will help the patient to do not go into the risk of fall. So these are the stages of at various stages we can use the orthotic intervention. And um, uh, if we see the how the technologically advanced material like get the FES system, functional electrical stimulus, integrated with AFO, how can that be used and utilized for Parkinsonism is again a research work which is already going on. So I think orthotic intervention will help the a person with Parkinsonism to have a confidence in their daily activity or daily living to be independent in their performing these activities. Thank you, Gua.
Thank you very much, sir, for highlighting the importance of these orthotics in patients with Parkinson's disease. And now we have completed one round of question to all our panelists. I request few words of wisdom from my mentor, Dr. Nirmal Surya, sir.
Thank you, Guhan. Now, you know what you have brought out, that Parkinson disease is just not a neurological issue alone. And just by writing down Syndopa or one of those drugs are not only the solution. You can see that there are so many problems which can be existing. And as a neurologist or as a physician, whosoever is treating, he has to look into all of this and guide their patient how they can be helped out, because it may be possible that everything is not there in one patient, but in some patients something is there. So we have now a question right here, and I think that question really pertain to not one specialty, that my mother, she do not listen, she walks away, we tell her to support. So, you know, they are trying to prevent her fall by telling her that you take a support. Physiotherapy can guide them. So, you know, and cognitively. So, Urvashi, I would like you to answer that. How do they handle this? We are not able to handle. She do not listen. She just walks away. Her daily activity, we are worried. I think these are very, very relevant point brought by one of the patient, because they are facing 24 hours a day, 365 in a year. And they are worried even if they go out for a party or even they go office, they are worried. Mother might fall, I might just get a call that she has fallen or she has disappeared somewhere. How do we handle this? I think everybody should tell us how to handle this. And this brings that, you know, beyond pharmacological treatment. Thank you, Guhan.
Thank you, sir, for the wonderful words and for wisdom that highlights the importance in Parkinson's disease. Dr. Urvashi, ma'am, would you like to highlight from your side on how to overcome this important problem, ma'am?
I saw the comment. I was in fact reading it right now. I think it's from Mr. Anand. So I'd just like to start, Mr. Anand, by giving a very quick, very brief overview for you to understand a little about mood, behavior, and personality changes which occur in personality in Parkinson's disease. And then I'll come to your question. So maybe that'll give you the background to understand. So first of all, as far as Parkinson's disease is concerned, it's very, very common to have mood issues, behavior issues, and personality issues. In fact, it has been said, you know, somebody's used the term prodrome here. Prodrome means something that has started even before you see the motor symptoms. So in Parkinson's disease, it has been suggested that even prior to the motor symptoms coming and you got the diagnosis of Parkinson's diseases, there may have been some subtle changes already happening in personality, mood, and other things. Now, why do they happen? There are two components to it. One is, of course, the neurotransmitters. We talk about the neurochemicals. We talk about dopamine depletion and how that impacts the mood and the behavior. That's the part of the disease process. But there's also the psychological part of the whole thing. And the psychological part is that one is receiving that diagnosis. When you receive a diagnosis, both as a caregiver or as a patient, it's almost like I mean, there's a term in medicine they use as therapeutic nihilism. Like it's almost saying to the patient, there's nothing much. It's a degenerative condition. You'll go ahead, it'll progress. So accepting that and really being able to handle that diagnosis and then adjusting it to it and then feeling that I'll still come out of it and I'll still do it is a huge psychological process. And then along with that is the chronicity of the illness. It lasts for so long. And as it is progressing, so many problems start coming one by one, which can completely wear you out, particularly as a caregiver. Now, coming specifically to what you were asking in terms of what are the mood and disorders that we see. Depression and anxiety is very common. And I think all of you will agree that at some point in that Parkinson's disease, whether you're caregivers or patients, you have felt low mood, you have felt frightened, you have felt worried, you have felt anxious. But one thing that is very interested only in Parkinson's disease is what we call dopamine-related disorders, disorders of motivation. So motivation is apathy and impulsivity. So you wrote the word impulsive there. That's why I'm bringing it up. So apathy is a term which people don't understand very clearly. It's about, what patients tell us or families tell us is he's become very indifferent. He's become very self-absorbed. When it's someone's birthday, he's not bothering about it. When I'm falling ill, the wife will tell us he's not concerned about me. He doesn't seem to be bothered anything. He's just completely self-absorbed. He's indifferent or uninterested in his environment. But along with it, you also get impulsivity. That is, they start doing something without thinking. You said impulsively, she goes into the garden. Now, it may have been a habit formation. It may be part of her impulsivity, which is coming from the dopamine depletion in her brain. But this impulsive motivation-related behaviors are very, very, very common. And we also have one thing which happens rarely, but it does happen, is called the dopamine dysregulation syndrome, in which the person, there may be hypersexuality, they may shop a lot, they may talk a lot, so almost manic-like symptoms. So all these bizarre symptoms do come up, and we are at a loss to understand that why with a motor disease like Parkinson's are they behaving in these strange ways. Now, what do we do with them? So also personality, we get the report that they're rigid, they become stubborn, they're irritable, they become rude. I had a doctor who cried in my clinic who said, my husband is telling me that I'm the most terrible person. I've given up my practice. I'm sitting there looking after him from morning to night, and he's constantly aggressive and rude and mean to me. So this also caregivers go up. Now, before I go to the other points for all the caregivers, to answer your question, Mr. Anand, what becomes very, very important when we look after people with Parkinson's is structure and timetable. When you say she's just wandering off, it's maybe often the impulsive behaviors come when there is a lack of routine, when there is empty time. In that time, this impulsive behaviors start coming. And then if they happen too often, they become a habit. Then to break the habit becomes difficult. So you have to first bait that circuit, create a kind of a structure, a timetable where she's engaged properly. And initially, you may need some kind of an attendant around her to distract her, divert her, put her into that routine so she's well engaged. And then we can select the activities which have the safety measures in it. Of course, if I meet you one-on-one, it's different. I can't tell you all the strategies now. But the key to this is to control those impulsive behaviors. And since I'm at that question, Dr. Gohan, I'll take a minute more and just complete this thought for other caregivers of what you do. So there are a few pointers I want to tell all of you is, first, it's critical for you to understand this brain behavior relationship. You have to understand that this person in front of me is not my husband, not my father. You are stuck with that role identity. My father was like this. My husband was like this. Why is he saying this to me? Why is he behaving like this to me? And you cannot accept that person. First, understand that there is something in that brain, the chemicals. It is the chemicals that are speaking, the abnormal chemicals. It is the disease which is speaking, which is bringing that behavior. That is not your loved one. So don't judge him and react thinking of him as the loved one. So instead of the reaction, to be able to accept, understand, and then identify triggers. What are the situations in which this behavior is getting provoked? Is there something that happens that she starts going at that time to go for a walk? Is there a pattern? So start identifying the triggers, and then with very challenging behaviors like visual hallucinations, delusions, which everyone finds so difficult to manage, you have to first don't argue, don't confront the patient. Non-threatening, non-confrontations, non-judgmental, talk to the person and say, okay, you are seeing this is happening to you. I understand. Don't counter argue. Divert their attention, try to engage them in something else and move them away from that. So there are many ways in we can address this rather than become confrontationist. Second thing and last thing is make them feel contributory still. The dynamics in a family change. So often the patient with Parkinson's, the male will tell me, my wife has become boss lady. She's all the time telling me, do this, do that, don't do this, don't do that. You're not exercising, you're not listening to me. The role reversals that happen, the dynamics in the family that change, we have to be mindful of that. We have to keep the dignity of the person. If that was your mother who was in a position of authority, if you say, I keep telling her, but she's not listening, she won't like to be told. She's not going to respond to that. So there are other ways to handle them and make them feel precious, acknowledge their position. Fix the environment. Don't change the environments. Don't change things around or their furniture. Don't take them on vacations in strange new places thinking I'm taking them for a nice holiday. It'll disorient them and confuse them completely. So avoid changing. And of course, professional help. We are there to work with you for strategies, individual. Then cognitive behavior therapy is there for depression and anxiety. And now they're talking about even neuromodulation for depression and anxiety, the transcranial and other, take those neuromodulation strategies. So I don't think I may have answered your question fully, but please do seek a consultation with a good psychologist and they will definitely tell you how to control that impulsivity. Thank you.
Thank you very much, ma'am. Mr. Anand sir, that was a free consultation for you from the top cognitive psychologist in the country. Hope that answered your doubt. Next, we proceed to Dr. Abhishek Srivastava sir, the chair of the session, for a few words of wisdom from sir at the end of round one. Over to you, sir.
I think just like the term is being used, motor and non-motor symptoms in Parkinson's disease, we go to MS, something called as invisible disability. Same way in Parkinson's patients, there are a lot of invisible changes, which are primarily due to autonomic nervous system involvement. People have postural hypotension, they have drop attacks, people have significant pain, bladder problems, constipation, and they will never tell you these things. We have to ask specifically, especially postural hypertension and pain. Pain is very common in PD. One, because of the tight muscles. They all have, actually, many patients go to ortho with frozen shoulders in the beginning, and they ultimately come to have Parkinson's disease. Same way, they are tight muscles, stress on the knee joint. They go to orthopedic surgeons for knee osteoarthritis. Comes out to be a PD. So one is aging causing changes, and second, tight muscles aggravating that pain. Always ask for pain. If you treat pain, then mobility and therapy is much more better. Same way, common reason of fall, which is not just lack of balance and coordination, it's the postural hypotension and the medication the elderly people take for bladder symptoms, which also cause postural hypertension, a lot of falls. Please ask for it. And third, bladder and bowel, all of them will have urgency. All of them will actually have constipation, which affect their quality of life significantly. So please ask for drop attacks, ask for bladder bowel issues, ask for pain, and treated, the quality of life will be much more better without. Thank you.
So there's also a question about pain from one of the attendee. What are the most common causes of pain in Parkinson's disease and how to approach it with pharmacological therapy, sir?
So again, the top to bottom, first and most common are degenerative conditions. These are elderly people with tight muscles. So your neck pain, back pain, spondylosis, arthritis, aging, osteoarthritis is the number one reason of pain, which will be mainly in neck, back, and knee. Second is frozen shoulders because of tight pectoral muscles with addition of diabetes with age also cause a lot of pain. And third, the tight muscles itself, the rigid tight muscles itself can cause pain. And mostly the hamstrings are very tight in such patients. They will respond to hamstring stretching. And as well as injection botulinum toxin also helps reduce that pain.
Thank you very much, sir.
They can have neuropathic pain because of other issues coming up with them, but the primary reason for pain is musculoskeletal.
Thank you very much, sir, for the wonderful summary of answers on pain. And now coming to the second round of questions. And in this second round of questions to all the expert panel, I kindly request you, since we are short on time, we will limit the answer to 2 minutes if that's okay with all the expert panelists. Thank you very much for agreeing to it. So we will start with Dr. R.K. Dameja, sir. Like Dr. Nirmal Surya, sir, just started his words of wisdom that medications alone are not always enough. And there's a whole world of non-drug therapies out there, but are really people open to exploring them? How open are patients and caregivers, sir, to these non-drug therapies, and how do you guide them as a neurologist, sir?
Thank you, Dr. Guhan. I think the pharmacotherapy and non-pharmacological measures both go hand in hand right from the beginning of the diagnosis. So it is important to talk about, discuss with the patients and caregivers about the role of pharmacotherapy as well as non-pharmacological treatments. So normally we start the treatment, drug treatment I'm talking about, when the patient starts getting functional impairment. If you can manage without any medication, as long as you can, that is the best thing. Then once you have a functional impairment, then you start dopaminergic replacement therapy in terms of, in the view of levodopa and dopamine agonists, depending upon the age and depending upon the severity of the disease. So that is one thing. Your question about the non-pharmacological method, which includes the physical exercise, the cognitive rehabilitation, as well as the balance, the strengthening, and other things, they are equally important. In addition, the diet is also very important because many of the drugs interact with the proteins, and so we advise them to take the medications either before the meals or avoiding the milks and other high protein diets with the medication. So that is important to tell the patient that diet, nutritious diet, balanced diet, not taking high proteins with the drugs, and avoiding caffeine and avoiding milk, particularly with the medication. That is important. The role of physical exercise, physical therapy is very, very important. And nowadays, it is recommended that when the patient is diagnosed with idiopathic Parkinson disease, at the same time, the referral to physical therapist or the physiotherapist is a must. And they can plan, they can have a discussion with the family about the goal setting, and then working towards that goal in a measured way, getting that functional improvement over a period of time. So that is important. The exercise is something which we have been advocating. In addition to physical exercise, the cognitive rehabilitation, which Dr. Roshi also elaborated about, the using your brain cells very effectively, that is again important, making the connections, making the brain cells, challenging them, and having a cognitive reserve and cognitive fitness. In addition, the postural hypotension, which we talked about, the lowering of blood pressure because of the disease as well as because of the drugs. Again, you have to have a lot of fluids, increase the salt, have the elastic stockings. And once you are out of the bed, take it very slowly, sit on the edge of the bed for 2-3 minutes, and then go to the washroom, not immediately rushing to the bathroom. That can also have a syncopal attack or a fainting attack and blackouts. In addition to this, of course, the changing the environment, as Dr. Rishi already told, about having the cognitive impairment. Most of these patients will have the memory problems, the neuropsychiatric problems. So that again has to be taken into account with non-pharmacological methods in addition to the pharmacotherapy. Thank you.
Dr. Damija, you have done a pioneer work on tele-rehabilitation in Parkinson disease. I think there are many patients who are online now, who would also join online on YouTube. They would really like to know that, they may not get expert in their small place. What is that and how that can help the people in the remote area? I would like you to highlight in next few minutes, because it is very important that today tele-rehabilitation could be the key in country like India.
Absolutely, I couldn't agree more. The tele-neuro rehab, particularly our work on tele-neuro rehab in Parkinson disease, is very well known across the globe. So what we do normally is a hub and spoke model also, where the mixture of in-person and the remote telemonitoring or tele-rehab is done together. So the tele-rehab in patients with mild to moderate Parkinson's is very well documented. It is feasible and it has equal results as in-person rehabilitation. So a one or two sittings in person and then followed by WhatsApp or video calling and having a video logs under supervision of therapists remotely on a WhatsApp call is very well uh, possible, feasible, and equally efficacious. So I would recommend that you talk to your physical therapist, have a online consultations or online physiotherapy sessions, and I can tell you that it's equally effective. It reduces the travel time, it reduces the cost of traveling, and it has equal results.
Thank you very much.
Thank you, sir, for highlighting the importance of the exercise rehabilitation and the tele-rehabilitation as well. Now, coming to Dr. Urvashi Shah, ma'am, Parkinson affects the whole family, mood swings, personality shifts. It can confuse and distress the caregivers. So, how do we help them cope? How can caregivers support patients who exhibit mood swings or personality changes?
Thank you for that. I think quite a bit of it I covered when I was answering Ms. Anand.
Ma'am, your voice is not heard, ma'am.
Now, can you hear me?
Yes, ma'am.
Yeah. Okay, so I think quite a bit of it I covered when I spoke of Mr. Anand's particular case. I said all those things, but just to again reiterate, the most important thing is for caregivers is number one is to understand the disease. I mean, why is this behavior or why is this mood changing, to be able to understand it. If you're able to understand it, then automatically, spontaneously, solutions, compassion for the person, empathy comes. Otherwise, you're going to burn out, because over time, when you are with a loved one who is not behaving appropriately with you, and you are there from morning to night doing things, it's bound to affect your health. Number two, for caregivers, therefore, your health is primary also as much as the patient's health. Remember, it's a chronic, long disease. It's going to be many, many, many years together. So for your own sanity and for your own, and for the good of the person, rather than even you, you need to take your breaks. You need to have your respite. You don't have to feel guilty. Many caregivers end up feeling very guilty if they go out even for a little while. So no guilt, be practical, action-oriented, seek help. How do you seek help? You have to involve some professionals at some stage. If you are in places where the good professionals are not there, then through tele-rehabilitation methods, contact, get your strategies. It's, if you can afford it, having one attendant who can help you, be there with you, who can be trained also, so that you can get your breaks. Then whether it is cognitive work that we want to do, cognitive strategies, the structure, the timetable, the recreational activities, the hobby activities, using the brain, use it or lose it. When we are keeping them well occupied, the mood automatically settles and they do much better. So creating structure, having help, having support, and then the caregiver support meetings. You also need a space where you can come and talk frankly that I'm really fed up, or this is happening. What do I do? Sometimes your own other people who are caregivers will give you wonderful solutions, even solutions better than what we can give you as professionals. So keeping that in mind, socialization for your patients. Make sure they don't get isolated in the home. The ability to take them and meet other people, that will help the brain. So if you learn how to do this, protecting yourself, proper structure for your client and your patient, no negative, guilty emotions, no reactions to the person, understanding the disease, it's very possible to live with people with Parkinson's as very positive caregivers and an enriching life for yourself. So these are on the surface that I've told you, but there's much, much that you can do. But first, take care of yourself.
Thank you very much, ma'am, for highlighting the importance of how to cope with these things. And now coming to the next question to Dr. Radha Bhattacharya, ma'am. Some days motivation hits zero. And in Parkinson's disease patients, how do we keep people moving even when their bodies and their minds resist? What strategies can help overcome fatigue and maintain patient motivation? Over to you, ma'am.
Yeah. Well said, sir. Fatigue is one of the things which definitely comes into the picture. I would say we should respect fatigue because they their cardiovascular endurance is reduced. Even their respiratory muscles are involved. Even their movement muscles are involved. So we should respect the fatigue. What we can do is we can break this exercise sessions or the strenuous work that they are doing so that they don't have fatigue a lot. So breaking the sessions is one solution to it. And as already discussed, we definitely need to have a routine for them. When they are in routine, they know what is to be done next, how much is it is needed to be done. Next is point of motivation. Definitely, I agree with this because of their non-motor symptoms, depression, anxiety, and all are definitely there with them. Along with it, we are asking them to do so many of the therapies. You have to do this, you have to do that, you have to do that. So, what can be done is so that they are there with you throughout the journey for physiotherapy or for various sort of the therapies is we should have our exercise regime. I call it as PM, which is it should be personalized. The exercise program should be personalized, and M is meaningful. It should be meaningful as well as it should be personalized to the person so that it is clear for it. And there are lot many alternative therapies or mix match of therapies that can be used to keep them motivated. Every day when we are being asked to do 10 repetitions of this, 10 repetitions of that, we also become bored with it. So it is always better to keep them motivated, incorporating mix match of the exercise sessions. And there are a lot many other therapies like brain gym exercises which targets your movement also and cognition also. There's dance therapy. So such kind of therapies like dance therapy, brain gym exercises, or I would say drama therapy is also there, where we can tackle their motor symptoms, their speech, their facial expressions. So such sort of therapies which are music therapy where it induces relaxation, can solve the stiffness also to some extent. So such therapies should be incorporated in between. So doing the same type of exercise, monotonous protocol, is not good for anyone, not even for us. So it should be designed in such a way that it is very creative. They find it enjoying doing that particular thing. Plus, they can join some support groups because going to the support groups, caregivers also get the help as well as the patient also get the help. They need to talk to people who are also going through the same phases of their life so that they know how other is keeping themselves motivated, or if other is going down they can help them being motivated with all these things. And tele rehab is also one of the solution, definitely, because every day it becomes tiresome for them. So some days home exercise which the caregiver can take, sometimes teleconsultation is really beneficial in the early stages, first or second stage. I would say the early stages, definitely yes, where we don't need that much of supervision for the exercise. So overall concluding, I would say the sessions should be very much well planned, motivated, variety of exercises should be there, change in the exercise pattern, exercise sessions, and integrating other therapies needs to be done to keep them motivated and their exercise adherence to the max.
Thank you very much, ma'am, for highlighting the important points that helps the Parkinson's patient strictly adhere to their rehabilitation program. Now, coming to our occupational therapist, Dr. Sriharsh, sir, falls are one of the scariest risks. And in fact, that's the point where patient starts to realize that something is seriously wrong with me. How can we make the homes safer and routines smarter to prevent them? What fall prevention strategies can be implemented at home? Over.
Yeah, that's a very important question, and this thing that as an occupational therapist we deal with, as I already spoke about the person, task, and environment approach. What we use is here goal plan do check. One of the questions that was like walking is as considered as an important part of daily living. It is not just a function, but it is an occupation. It is one of the meaningful things. So whenever we are doing walking, we see that walking as a function and not just an exercise. So first we acknowledge that walking is important for the patient, and then set goals around walking. Say, where do we walk? How do we walk? If we At what time do we walk? Example, setting a walking as a routine is very helpful, like how Urvashi madam said. An occupational therapist uses this goal plan, do check kind of a protocol where we actually plan. Like for example, if you want to go to a garden, so what kind of clothes you will wear? So the clothes should not be too, it should not come in the way of walking. So you need to select the right kind of clothes that you are going to wear, right kind of assistive device, like what kind of walking aid you are going to use, and what kind of time you are going to do, especially if you are on Syndopa or any of the cholinergic drugs, you need to understand when that drug is going to act better, and in that duration of time, if walking is taken, so the person enjoys this as an occupation. Also, the most important thing is frequency, like how many times in a week we are going to go out, and setting that frequency. When you are clear about the structure and the routine, the person's participation is improved and the risk of fall reduces. Also, talking about the exercises, rather than doing a rote kind of exercise, we need to incorporate movements which are already a part of patient's repertoire, daily repertoire, like going downstairs or in the known environment, and modifying the environment by installing grab bar. The most important and the most prevalent fall risk and the consequence of fall is fractures of the hip. So, and the most crucial area is the bathroom. So we need to see to it that the caregivers make the bathroom more friendly for people with Parkinson's by making them non-skid, having a grab bar installed, also having a grab bar installed throughout the space where there is a mobility which is meaningful to the patient. Like for example, patient has to go to toilet, patient has to use the living room for watching TV. So see to it that these spaces are one accident free and also accessible. All the switches can be lowered down so that the patient need not stand up every time. Also, use of devices like tracking devices if somebody is having a wandering behavior like dementia associated or psychosis associated with Parkinson's, you can have a tracking devices on the person so that come to know about the patient's whereabouts. So making the environment and the whole entire experience of walking very conducive and acknowledging that walking is important and revolving your discussion and giving an autonomy to the patient, like making him or her realize about how much we can walk and how much is the a calculated risk and how much would lead to a consequence or a dire consequence or an accident. So giving that window, the idea about that window about safety zone of walking is also very important. So having the motor, cognitive, emotional, and psychological aspects of entire walking and fall is very important while you consider walking or fall prevention strategies.
Thank you very much for highlighting all the important aspects of fall prevention, because that forms an important anchorage in the rehabilitation of patients with Parkinsonism, sir. Now, coming to Dr. Jyoti Mohite, ma'am. Low volume monotone speech, it's not just talking softly, but how do you help them find their voice again? What voice quality issues are commonly seen, and how can they be managed in Parkinsonism?
Yeah. Especially with related to voice, what happens is because there is weakness and the respiration and phonation coordination is affected, their volume becomes very low. They become very soft. And as the disease progresses, this is going to deteriorate, their voice is going to deteriorate further. So in speech therapy, what we would do is initially is to make them do this vocal projection exercises. So LSVT loud is what is some most of you may know about it. Where it works, it is basically recalibrating their own system to make them feel that yes, speaking loud is normal. Because if they speak loud, only then they are going to be heard clearly, and then the communication breakdown is going to is not going to happen, or communication won't break down. So therefore, speaking loud is very important. So we'll work on those exercises, as well as because their intelligibility is also affected. So we will also focus on their precise articulation part initially. But as the disease progresses later, definitely we will have to resort to alternative and augmentative communication system. So we need to prepare them for this use of alternative and augmentative system also. Yeah, thank you very much.
Thank you very much, ma'am. Now, coming to Dr. Prasanna Hegde, sir, the swallowing therapist on our panel, no one should choke on their meals or fear eating. So, what are the techniques and therapies that truly make a difference? What therapies have proven successful in managing these issues, sir?
The first and foremost things I think we need to look at is early intervention, the time when we intervene. There are a couple of things that probably we need to consider because if you look at SWOT analysis, strength, weakness, opportunities, and threat, if we use the initial strength and have opportunities to further strengthen these aspects, probably we will be able to be prepared or postpone those aspects that we may deal later, which is going to be weakness and threat. And also, if you look at ICF classification, now faster you work, the later is the quality of life gets affected. So they might have inevitable physical challenges, health issues, but they still will be able to function about it. So faster we do certain things. Now, it could be facilitation exercises because right away there may not be challenges. There are certain indicators, probably they're trying to manage saliva. So these are all the aspects that will tell us that, okay, start doing exercises so that what is going to come further is going to be looked at. Now, again, why we look at early intervention? Because higher risk of secondary problems are, avoided. There are no risk of aspiration. Hospitalization is again going to be a challenge because of the pneumonia or even comorbid conditions like other aspects. Ambulation is going to be a problem. Now, having an ambulatory problem and having risk of aspiration is like a double whammy. It's a double problem for us. So, and even issue with voice, like, it could be a weak voice, which is going to be further creating problem with swallowing and other things. So, there are compensatory and facilitatory strategies. And now we look at whenever there is a problem, we initially would like to do compensatory because you need immediate success. Because you know that persons with Parkinson's disease, initially they seem to be very confident. They don't have insight that they have a problem. And as they go on, they swing down to have low, self confidence. Because we need to look at all those aspects. Because for us, a person who is denying the problems, is better to treat than the person has the willingness to improve. So we can easily break somebody saying that, no, I don't have a problem at all. We can always give feedback, but somebody is already giving up. Then I think we should be, looking at early identification and intervention in those aspects.
Thank you very much, Dr. Prasanna Hegde, sir. Now, coming to the orthotist in our light panel, smart gadgets are smart only if they are useful. Can the data these tools collect can be turned into real actionable care, sir? How can data from these devices be used to improve patient care, sir? Over to you.
Yeah. So, as we said, data from the gait analysis, the walking, risk of fall, everything comes with the movement. So, if we have a proper assessment, proper observation on patient, what kind of trouble the patient is having, and uh, how they want to improve themselves, or how they want to prevent that particular cause. So with that, the orthotic intervention or the therapeutic intervention will help the patient to overcome over the problem. So as we see in the chat that the father of Ananda was asking regarding if is there anything if my child is getting uh, uh, rigidity during walking and all. So with the continuous therapeutic program and orthotic intervention, I think, and in medicines, I think it is possible to overcome with the problem, the rigidity problem, what they have mentioned.
So thank you very much, sir. Next, it is never complete without discussing on the technology in all aspects of rehabilitation. Now, pertaining to Parkinson's disease rehabilitation, I kindly request the chair of the session, Dr. Abhishek Srivastava, sir, the expert physiatrist, on to if sir, can you please highlight on the new technology in Parkinson's disease rehabilitation? Over to you, sir.
Yeah, very important question. People always ask us every day. Now, technology is being used for all types of impairments in Parkinson's disease, but is most commonly used for motor symptoms. A lot of work on exergaming, home-based therapy with with you can have an Xbox at home, you can play tennis, badminton, football with the children, grandchildren. It's very, very important usage and being used worldwide. Very important. Second is with VR training coming in, working with balance and coordination. There are some roles, some studies to show it has some role to play. Body weight support system and robotic assisted gait training also useful in people who are losing their mobility at stage 2. A short course is helpful. Now, neuromodulation is coming in RTMS and TDCS, currently in phase 2, phase 3 trials, improving motor function. Same with technology, especially vital stem, is now being approved and very commonly used to improve both dysphagia and dysarthria in patients with Parkinson's disease. Same way, cognitive function. Again, there are some trials to show promising results with neuromodulation and neurofeedback techniques. Technology definitely is currently being used for improving motor symptoms, especially exergaming and robotic training, and vital stim for dysphagia and dysarthria. And I hope in future, in next 5 to 10 years, there are a lot many more approvals by FDA for using the RTMS and TDCS and VR technology in improving, I think, most of the impairments in Parkinson's disease. Thank you.
Thank you very much, sir, for highlighting on the importance of technology. Next, I come to the chair, Dr. Nirmal Surya, sir, to summarize on the public awareness in Parkinson's disease rehabilitation beyond the pharmacology, sir.
Thank you, everybody, for giving your insight and point of view from your specialty. I think it is very important for people suffering from Parkinson's disease or their caregiver and the community to understand that what this disease is. It is just not like diabetes that you have high sugar and you take insulin. Similarly, you have dopamine deficiency, you take dopamine. It is much, much more beyond that because it is brain, and how a person's brain react to different situations in different times and in different ways is entirely different. And therefore, everybody has to plan out as per the tune of that person. We heard about what are the Parkinson disease symptom from Professor Dhamija, and also we heard about tele-rehab from him. We heard about cognitive mood, behavioral disturbance from Dr. Urvashi. We heard about the motor function from Radha. We heard about activity of daily living, which is very, very important to support every day, to go to toilet, dressing, bathing, which are very important for a person from Drs. Jagirdar. We heard about the speech, how communication is important from Jyoti, and swallowing, which is a very important function from Prasanna. We also heard how the assistive technology various can help and with freezing phenomena, things like a laser stick and other walkers, which are very, very useful for many of these patients to prevent the fall. We heard about the latest technology from Abhishek, about what are the new things are coming. Here I would like to point out one very important thing is that there are a couple of points which patient, relative, and caregiver are always concerned. One of them is the disability certificate. And I think it is very important that the caregiver understand that Parkinson's disease is one of the disability which get exemption in income tax, nearly an X amount from the tax, so that they can take benefit for that. And also they can get the disability certificate depending on the patient disability to have their benefit in day-to-day travel, train, etc. So that is something which many people do not know, and I think someday will come out on Disability Day about the disability assessment and certification from the team so that it can help the common public. Also, many of our caregiver and patient cannot afford the various technology, various therapies. Remember, doing the activity, as Urvashi mentioned, things like, regular activities, music, dance therapy, yoga therapy, walking, doing the various activities, playing with the children, as she told, could be equally effective. Do not think that they are just like routine thing. They could also have. Main thing is they need to be busy in activity and a schedule. So I think we have given you guidelines. We have given you, there are much more. In 90 minutes, we can only give you what is there. But you decide what your patients is having the issue and who are the best person can help in this situation. And then you connect with them to help you out. And I hope that we will get a cure in future with genetic link coming and gene therapy coming. Till that not come, and not to forget those who are very disabled, not better with medicine, surgery of DBS is available. We will come back to that some other day. Thank you very much, Guhan, for giving me this opportunity to sum and start. Thank you very much. I hope it has been useful to all the people who are listening to us. Thank you.
Sir, your voice is muted, Abhishek, sir.
Two questions, just take in short, just one line, somebody can answer.
Okay, the first question is, since it is not curable, can we avoid medicines to avoid other side effects and stick with exercise and physiotherapy?
Dr. Dameja, sir, please.
I think it's not correct that you should not take the medicines and take only non-pharmacological or non-medical measures. Always consult a neurologist and take the advice, and the drugs are required. Treatment is available, and it's very efficacious for controlling the motor symptoms, and nowadays non-motor symptoms also.
Thank you, sir. And coming to the next question, is psychiatric counseling required in Parkinson's disease? Dr. Urvashi, ma'am, can you?
So as I said, some depression and anxiety happens in all the patients. So they all don't need to go to a psychiatrist. But if the depression or the anxiety or the behaviors reach proportions where they are now interfering with the person able to even conduct his daily life, or they've become too challenging for the family to handle, then definitely 100% a psychiatric consultation is required. Very often when we advise doing screening at baseline also and following up with the patient, or your neurologist is doing it, please talk about these symptoms with your neurologist. They are good judges to tell you that now it's time to also, they will refer you to a psychiatrist colleague if mandatory or required. But I'm sorry, it's not mandatory. If required, then they will refer you. But in the early, in smaller things, we can definitely, with some strategies, manage that.
Thank you very much, ma'am. And as we come to the fag end of the public awareness program today, words cannot merely express my thanks to my mentor, Dr. Nirmal Surya, sir, for always motivating me and making me believe in me that I can moderate the expert panel. Thank you so much, sir. I'm forever greatly indebted to you for that, sir. And I thank Dr. Abhishek Srivastava, sir, the chair of the Neuro Rehab subsection, for guiding me in every single step that I take in neuro rehabilitation, sir. I thank the Presidium, Indian Academy of Neurology, for endorsing this session. I thank the Presidium of the Indian Federation of Neuro Rehabilitation, the Developing World Forum of the World Federation of Neuro Rehabilitation, and the Movement Disorder SIG of the World Federation of Neuro Rehabilitation for coming together to make this event a grand success. And I hope every single attendee here has benefited from this public awareness program. And it's my great duty to thank all our expert panelists, Dr. Dameja sir, Dr. Urvashi ma'am, Dr. Radha ma'am, Dr. Srihash sir, Dr. Jyoti ma'am, Dr. Prasanna sir, Mr. Lukesh sir, and to every caregiver, family member, and person living with Parkinson's disease who has joined us today. A very small word, but it takes a big leap. Don't worry, every patient out here, we are all here to support you. Stay tuned, and we will come with more public awareness programs in the future. Thank you very much.
Thank you, everybody. We
Thank
look
you.
forward in future.
Thank you, sir. Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.